Hello, everybody. My name is Prachi Bakrania. I'm a scoliosis spine specialized physical therapist here at Columbia, and I have the pleasure to serve as your moderator today. Today's topic is about tethering decision making and post-operative physical therapy. I'd like to introduce our first speaker. He is the driving force behind all the non-operative scoliosis and spine work we do here at Columbia. Dr. Michael Vitale serves as the chief of the Pediatric Spinal Surgery Service and director of the Pediatric Orthopedic Division of the Children's Hospital of New York Ox-Spine Presbyterian Hospital. He also serves the co-director, along with myself, of the non-operative scoliosis and spine care physical therapy clinic. In fact, he was the first orthopedic surgeon in our country of his stature to voluntarily search for non-operative options for his patients and his family. So without further ado, my dear friend, Dr. Michael Vitale.
Dr. Vitale, you're on mute. Okay, so just.
Thanks, Prachi. Very kind of you. I think, as anyone on this webinar knows very well, doing something impactful in this space really requires team. And I feel so fortunate to have a great team helping us to deliver the best outcomes to children with scoliosis. So I want to thank Prachi, Trella, Amber, Amika, and some of the other people on my team for working so hard to allow this all to happen. I know people are just logging in. We got started just a bit early, so I will just use some housekeeping notes. Please feel free to send questions to Prachi via the chat. We will do our best to respond either online or offline. We might be able to follow up afterwards if there's something in particular you want to give a question about. This is the inaugural launch of our Lunch and Learning series. Many of you may be familiar with our conservative scoliosis program. I think we are now in our 8th or 9th annual year of our conservative scoliosis program, which happens every June. Please save the date. June 20th, 2024 will be the next non-operative scoliosis program here at Columbia University Medical Center. More details to come on that. But it became obvious along the way that a single touch with our community was probably not enough. And our team got together and started thinking about how we could better engage, better interact, and better support the community of interested therapists, patients, surgeons, orthotists, pediatricians, and others who are involved in this conservative scoliosis care space. And with that, the Lunch and Learn program was born. There are over 200 participants registered for this first program, and our plan is to have this program every 2 months. The next one will be in June. And I want to thank you for your interest, and with that, speak a little bit about the agenda today. We will start off a little bit with a talk on anterior vertebral body tethering. This is a procedure that I've been quite involved with, although as you'll hear, I have moderate enthusiasm for the procedure, because I think success of this procedure is so dependent on choosing the right patient, as well as details of technique, and as you'll hear from Trella and others, the post-operative care of these patients. I'll speak a little bit about tethering, the history, indications, potential benefits and risks compared to a more standard posterior fusion. And then you'll hear from our outstanding Schroth therapist, Trella Allen, who will speak with you a little bit about some of the techniques to maximize and optimize patient outcomes after anterior vertebral body tethering. So with that as a background, I will launch the first of our PowerPoints here. Okay, again, well, welcome to the inaugural Columbia Conservative Scoliosis Lunch and Learn, where today we will focus on anterior vertebral body tethering. I have some disclosures, most important of which is that I was pretty involved in the development of the tether with ZimV spine for the last 6 or 7 years. A number of us have been involved in trying to understand how to improve non-fusion outcomes in this space. And although we're getting better, this is a journey, and you'll hear more about that. I also do a lot of research on this in this space. This is a time where we have lots of deadlines for meetings, and we just this weekend we're deeply involved in final preparation of abstracts around various parts of tethering. So here's the reality. The results of new treatments often look very good at the beginning. There's a period of enthusiasm with new treatments where we don't understand the full range of outcomes in that very early period. But over time, inevitably, generally for every procedure, for every pharmaceutical, for every medical intervention, the results degrade over time once we do enough research and have enough follow-up. And unfortunately, it's easy to be stuck in a cycle of enthusiasm where you, as a thought leader, think you are always on the newest new thing, delivering the best results to patients, but in reality, that's not the case. And I think whenever we adopt a new technology, whether it's surgical navigation in the operating room or vertebral body tethering, we need to be cognizant of these realities. It's one of the reasons why we've taken a very formal approach with study groups formally studying the results of vertebral body tethering. I get to help lead the Pediatric Spine Study Group, and I'm involved in the HARMS study group. And these two groups have literally hundreds, getting close to thousands of patients with tethering. And this has greatly accelerated our learning curve and our understanding about options, indications, and outcomes. You'll remember that about 10 years ago, there was similar enthusiasm with the technique of vertebral body stapling. And based on some early studies showing reasonable success, at least in smaller curves, a number of us, including myself, jumped in and did a number of these stapling procedures. While I still follow some of these kids 10 years later, and many of them are doing quite well, the reality is, over time, our group and others published that too many of these early stapling procedures continued to progress and showed minimal growth modulation over time, with many of them ending up having a posterior spinal fusion. And I think about that a lot as I help think about how to speak about and educate on the tether, and as we think about how to best improve the tether. In 2014, my friend Amir Shamdani in Philadelphia published the first cohort of children undergoing anterior vertebral body tethering. And what he showed was very reasonable results at 2 years, with improvement in the thoracic curve and relatively low rates of revision surgery. And now, fast forward some years later, there's been lots and lots and lots of excitement, publications, and experience in anterior vertebral body tethering. And this has helped us learn quite a bit. And the way I would summarize it is, it's very, very, very clear that tethering, at least for a subset of our skeletally immature patients, may have a role. It's clear that for a subset, and we're still trying to understand why it's not for the majority, tethering allows effective growth modulation. And I think we're starting to understand that about 85% of patients have outcomes where even if the curve is not fully corrected, the curve stays in a range where they can avoid fusion. But there are complications. The complication rate is higher than with standard fusion, although the complication rate, thankfully, is decreasing over time. The classic indications and the indication for which vertebral body tethering was approved by the FDA are single flexible curves, 40 to 60 degrees, in children who are skeletally immature just before peak growth. That corresponds to Sanders 2 to 3, after triradiates are closing, and really around the time of menarche in a young woman. These curves need to be relatively flexible, and there's lots of considerations about whether these tethering is appropriate when there's a larger lumbar curve, the so-called 1C type of curves, or when there's significant shoulder imbalance, because we can only tether so far up. Really, T5 is about as high as we can go safely. So for the most proximal curves, we are unable to really obtain shoulder balance. But maybe the most exciting indication for tethering is when it allows us to avoid a fusion to L3 or L4. And I'm going to share with you a case or two about that exact indication, because I think we all understand that the alternative to a thoracic vertebral body tethering, the alternative to a thoracic selective fusion is a good operation, but the outcomes of selective thoracic fusion are actually quite good. I don't feel quite the same when we start thinking about fusing a young kid to L3 or L4 because of issues related to mobility, flexibility, and a literature that generally documents not as good outcomes in the long term when children are fused down to the lower lumbar spine. And there is significant controversy regarding the appropriate indications for tethering. In fact, even if you look at experienced spine surgeons across the country, we really don't agree as to the best indications. And this is something that's evolving and something we need to get better at. Here is a snapshot of complications from our pediatric spine study group. And this was a study that was done a couple of years ago now, where we looked at 175 kids who were tethered and showed about a 16% rate of complications and a 6 or 7% change of unplanned return to the operating room. These numbers hopefully will continue to come down, but as we improve our learning curve and learn from our early experience. But when I counsel a patient, I generally say that for a posterior spinal instrumentation and fusion, the chance of unplanned return to the operating room is about 1% in the long term, not at 1 year, and the chance of complications is more like 3%. So the complications here are somewhat higher, and certainly the chance of a return to the operating room, either because of overcorrection, inadequate correction, or progression to fusion, is significantly higher than the chance of return for a selective thoracic fusion. This procedure requires a different skill set, so it needs to be done in a place where there's been experience in thoracoscopy, good anesthesia, because it requires single lung ventilation, and often a partnership with experienced pediatric general surgeons. And here are slides from Noel Larson's work looking at the learning curve here, and you see that outcomes, even in the first year or two, have improved for things like blood loss, operative time, anesthesia time, and length of stay. And again, we're all on a journey here where we're hoping to do better over time. I think a big part of this journey is understanding how best to communicate to our patients, and informed consent is really important. And this is part of shared decision-making that we use. And there are now formal shared decision-making tools that are about to be released that use a computer to guide families through the best available information. And this is how we, in our office, approach patients. And we basically say that there are two options, a fusion or a tethering, and here are the differences. This is what it looks like. And here are the relative risks and advantages and disadvantages of both. And I think we need to be honest that there's no question that we get less complete 3D correction with vertebral body tethering. We're not as good at restoring sagittal plane, meaning restoring kyphosis, and we're not as good at improving rotational issues. Also, I quote about a 15% risk of reoperation, again, compared to about a 1 or 2% risk of reoperation for the fusion. This is what both procedures look like. This is a selective thoracic tether done to T12 and a selective thoracic fusion. And they both take about 2 to 3 hours. Both of these patients are generally in the hospital for 2 to 3 days. Both patients generally miss about 2 to 3 weeks of school and are back playing sports in about 6 weeks. This is what it looks like in the operating room through a thoracoscopic approach. And then before and afterwards in a what I would consider a successful tether now a year afterwards, with improvement in the uninstrumented lumbar curve and reasonable sagittal plane. But what I'm going to talk about really, and Trella will then follow up with her experience in helping treat this child postoperative, is lumbar fusion. When you have a gymnast or a dancer or someone else who priority is to maintain lumbar motion, a fusion in this kid would result in loss of motion and probably some changes in postoperative function. And this was my first lumbar tethering some years ago, and this is this kid 2 years later. But again, you'll see that we've learned quite a bit over this short period of time. And now we're doing so-called double row tethers. And this is a case that we'll talk a little bit about. This is Talia. She's a 12-year-old. Both of her parents are Columbia professors, and they had a very, very, very strong preference to avoid a fusion. And if you look at that white line, that's called our center sacral vertical line, which is barely touching the L4 vertebra here, meaning that we would have to fuse to L4 to have the best possible radiographic outcome if we were doing a fusion. And for a competitive dancer, a fusion to L4 will almost certainly result in a change in flexibility, function, and return to that super high level of sports. So we spoke lots and lots and lots with her family, and they understood that we were certainly pushing it here because the curves are a little bit bigger than you would typically be enthusiastic about having a great outcome with tethering. And they understood that there was a chance that this procedure would need to be revised to a formal fusion. You'll see here now the new way where we're now managing lumbar tethers is with so-called double screw or double row techniques. Because one of the reasons why the tether failed earlier is because the tether would break prior to the kids finishing growing. And there's pretty good evidence now that using 2 tethers in the lower lumbar spine makes this better. The other technical point is that if we can affect a lot of correction on the table, and we're much more attentive to getting the curves as straight as possible on the table, it looks like we have better long-term outcomes. Remember, this kid had a 54-degree thoracic curve and is skeletally immature. So here's her post-op X-ray and a brace. And for larger curves like this, especially in younger kids, we'll often do a period of post-operative bracing with the hope that that'll help modulate growth over time. And I was thrilled to see her now at about a year afterwards, and she's actually coming up to the 2-year follow-up. I'll see her again in the next month or two, because this X-ray here was almost a year ago. And you see that she's had a beautiful modulation with both the proximal curve, the main thoracic curve, significantly smaller, and then the instrumented lumbar curve also smaller than it was directly post-op. In fact, the abstract that we just submitted this morning to a meeting called IMAST talks about spontaneous resolution of the uninstrumented curve during tether operations. And as you may expect, in those cases where you have significant correction and good modulation, meaning over time that the curve decreases, it looks like the secondary curve here, the main thoracic curve, spontaneously, more predictably resolves. And I'm pretty happy, and the parents are pretty happy about this result. But you'll hear from Trella in a minute that this took quite a bit of work post-operatively, and there are some important things to think about when you're caring for a patient after a tether, particularly with so much growth remaining, particularly with a large main thoracic curve here. So in conclusion, the tether definitely has a role, but we need to better understand indications, technique, and technology, and all these things are improving. We're about to do what's called design freeze for the last generation of tether, which means that it should be available in about 6 months after it goes through FDA regulatory approval. And there'll be many things that are better about the next generation. I still think that this requires a lot of time, discussion, communication, and maybe formal shared decision-making. Informed consent is critical because the family needs to weigh in and trade off what their preferences are with regard to options, with regard to fusion, loss of motion versus increased complications and increased chance of a second operation. I still do selective thoracic tethers, especially if a family is well-informed and pushes me. But I, on the other hand, am much more enthusiastic about lumbar tethers, especially when I know that I'm going to need to fuse to L4. And again, as you'll hear from our amazing team, outcomes here are critically dependent on a great team, including in the hospital before the surgery, but also afterwards. And you'll hear a little bit about how Trella really helped this child over time. So with that, I will pass off back to Prachi, and I'll stop sharing my screen, and just want to thank you guys again for your time today.
Wow, thank you, Dr. Vitale. That was really informative. I have so many questions, but before we get to questions, next up is my good friend Trella Allen. She is a trusted physical therapy colleague and here at Columbia. She might be new to physical therapy, but she brought a breadth of expertise surrounding her many years experience in yoga education. She's going to discuss a case she had with Dr. Vitale and her post-operative therapy intervention. Thank you so much, Trella.
Thank you so much. Thank you, Dr. Vitale, Prachi, and Amber for inviting me to share this case. As Prachi said, my name is Trella Allen. I'm a physical therapist for the faculty practice of Columbia University Program in Physical Therapy, and I'm happy to be here with you guys today. Before I start, I just want to make note that this patient worked tremendously hard. We spent countless hours in my treatment room dealing with pain, feeling different than her peers, not only the musculoskeletal issues that we were dealing with, but also the emotional issues. And her family was kind enough to let me share these photos of her. But if you would be so kind as to not take any screenshots of her images, she worked really hard, and I'd like to honor that and keep it that way. Thank you. So Dr. Vitale already shared this patient with you on x-ray, but here she is. She's a 12-year-old, now 13-year-old pre-professional ballerina. When we first met this patient at Columbia, her thoracic and lumbar curves were already in surgical range. So therefore, she'd never had formal therapy or bracing. She was diagnosed in September of 2022, and I met her first on October 19, 2022. When I met her on evaluation, she had 6 to 7 out of 10 pain in her left lumbar spine, and her curve measurements were 64 degrees in the left lumbar, 52 in the right thoracic, and 32 in the left upper thoracic. She was a Sanders 3 at the time, and if you follow the BSPTS classification, she was a 4C. I think it's important to note that as a pre-professional ballerina, she was a competent mover, and therefore she took on the principles of correction very well, which made treatment easy for her in that way. She was scheduled for surgery with Dr. Vitale for an anterior vertebral body tethering on December 14 of 2022, and she did prehab with me prior. So here are her images that you already saw prior. So here she is in October of 22 in the hospital with T12 to L3 fixation, and then again in May of 2023. The May images, she had 13 sessions with me, so 4 months of treatment, and she'd been in a brace in 6 weeks post-op. And at the start of treatment, I wasn't really sure what was going to happen. Our goal was to stable the compensatory thoracic and upper thoracic curves, but we're unsure if she would need a posterior spinal fusion anyway for that thoracic curve. And the results thus far have shown that with PSSC and bracing, or potentially something else after the lumbar tethering, we were able to stabilize the thoracic curve. And here she is in the sagittal plane as well. I think it's nice to see that her lumbar lordosis and kyphosis did improve since her tethering procedure. Here she is on clinical exam. The first picture was 2 weeks prior to surgery. I had 7 sessions of prehab with her. We used the laser line as a training tool during treatment, but you can appreciate her relationship of the lumbar curve to the central sacral line, as we also saw on radiograph as well. The second image was taken a little more than a month ago. I treated the patient for 16 sessions from January of 2023 to June of 23. And then she went to camp and we restarted, and I've been treating her since August again. But here she is clinically before and after. I did do prehab with her, as I said, for 7 visits. She participated in a rigorous and traditional physiotherapeutic specific exercise program. And I do think it's interesting to note that she was off narcotics before leaving the hospital, and she was back to school before expected. In fact, she was ahead of all norms when it comes to post-surgical outcomes. As a side note, we just recently started an IRB approved study, which investigates, does prehab specific exercise improve post-op outcomes for patients? She was obviously not part of the study, but it's just interesting to see. Let's take a look at the protocol that I used when treating her post-operatively. I have divided phase 1, weeks 4 to 7, because I progressed her quicker to the second phase due to the fact that she was in a brace at 6 weeks. Post-operatively, I used the Columbia post-op spinal fusion protocol as my base, and then I used my clinical judgment for a tethering procedure. So here we are at weeks 4 to 7, and I changed my approach after week 7. Throughout treatment, I did not use a traction belt, and I did not perform any hanging. That was my own decision. And in phase 1, all physiotherapeutic specific exercise was submax, and I only addressed the ribs and the compensatory curves. So her first visit was with me on January 12 of 23 this year. That was 4 weeks post-op exactly. And in her first session, we did sciatic nerve glides, transverse abdominis activation with marching and bent knee fallout, quadruped rocking, and then a lot of breath work in supine and standing. And I encouraged her to increase the breath expansion as her diaphragm relaxed. 5 weeks post-op, I added the supine and prone on knees position for those of you who know those positions. Third session, we did brace training. So here she is with this brace. John, thank you for an excellently made brace. And the 4th session, I added a reformer for lumbopelvic stabilization, as she had demonstrated in session that she could activate her muscles appropriately off of the reformer on the mat with my fingers. So then we were progressing her to the reformer already 7 weeks to To note, I did stress the importance of cardiovascular exercise throughout this entire process. So I had her walking every day. And she returned to dance at 6 weeks post-op and found that endurance was an issue for her. And it remained an issue for her. And so that was something that we continued to focus on as well. In the second phase, I call this week 7 to 12. We had some goals for her. She had a recital in June, and she wanted to go to this high-level competitive dance camp in Washington, D.C. in July. And so we had our work cut out for us. As I said before, she did go back to dance week 6 and slowly increased her participation over time. And in session, we worked with things like pain and endurance to help her get through that transition. In physical therapy sessions, we progressed all PSSE, and I added sideline on her right. And once she was in the brace, I made the clinical decision to increase the intensity of therapy. So essentially, I matched my work on the compensatory curves with the force of the brace. As a dancer, she had very clear goals. And so I was pretty rigorous with her. And so once she could demonstrate endurance with her muscles and neuromuscularly maintain that, I progressed her to the next muscle activation. I also progressed her lumbopelvic stabilization on the reformer by asking her to maintain her corrections while doing a progressive task on the reformer. So you can see her here. She's maintaining her corrections while she's on the reformer doing this position. I still did not use a traction belt, and I spent a tremendous amount of time addressing the compensatory curves. I addressed the upper thoracic curve with head positioning and in right side lying. Her head is positioned this way in all pictures, but you can't really see because her head is covered. The thoracic curve I addressed directly. And as I said, she was back to dance, and she did do her recital in June. And that's actually her in her recital. And this is also her here in her recital. So as I said before, we worked really hard in my treatment room. We would hold positions for a very long period of time. And I was pretty hard on her, actually, and made her really maintain what she needed to maintain in order to get back to what she needed to get back to. And she also made it back to camp in July. So in preparation for camp, we again intensified her treatment. And we not only progressed her PSSE to the positions that you can see her on the left, but we progressed her lumbopelvic stabilization on the reformer. So I would have her do her jumps on the reformer, and I would monitor to make sure that she was keeping neutral pelvis and not landing in her curve. And then we also performed every single arm position over and over again while doing her postural corrections, because she'd been given feedback that people could still see her curve, and she was in her curve when she was dancing. And so we spent a lot of time doing very sport specific movements with her PSSE corrections. So she did her recital in June, she did her camp in July, and she is now dancing as before, and able to increase her lumbar flexibility as well since her surgery. She's still growing and has grown since those May pictures, but she's very committed to maintaining her scoliosis specific exercise and her brace wear, and I'm still seeing her. And she works really hard in session. So here are her pictures, clinical pictures, but before and after. This is November before her surgery, and then a little more than a month ago. And then here she is in the sagittal plane. And then here's the most impressive part of it all, is this is her. She had a beautiful photo shoot in August. I do think she's sitting in her curve a little bit, unlike how we practiced, but she was able to have this beautiful photo shoot and return to dance in an unbelievable way that she may have never imagined. In fact, I know she never imagined, based on a lot of our talks that we had in my room. So what did we learn? One of my main takeaways from this case is the importance of providing individualized patient-centered care. Spinal mobility was very important for this patient as a pre-professional ballerina. Dr. Vitale was willing to perform a double tether on her. John made an excellent brace, and I worked with her on getting her back to dance as per her prior level of function. The merging of technology with the standard of care helped the patient maintain her goals. I also found that prehab prior to surgery was very helpful. It set expectations for the patient and the family, and it set the foundation for post-operative care, because when she entered my room again at 4 weeks post-op, she knew exactly what was expected, and she'd already been practiced some of her breathing even prior to entering my room again. As I said at the beginning, I had no expectations going into treatment. I didn't know if we'd be able to stabilize her thoracic curve or what would happen. And based on this case, it seems that PSSE embracing, or in this case, PSSE embracing, led to objective improvements on the compensatory curve post-lumbar tethering. And then, as with spinal fusion, a patient can have a safe and predictable return to sport at 6 weeks, because she did. And then, most importantly, strong communication between the patient, the parents, Dr. Vitale, Amber, John, myself, and her psychologist allowed for the best possible care for the patient. Thank you, everyone. I think I'm passing it back to Prachi.
Yes, thank you very much, Trella. That was wonderful. So let's start with just a couple questions that I've got our way. Is Dr. Vitale, I see there is a higher complication rate with a patient who's receiving tethering. Can you touch upon a little bit about if there's a difference in the type of complication? And I know also the way the surgery, like this, the actual, the insertion point of surgery is also different than a spine fusion.
Yeah, so, I think we need to sort of differentiate between the thoracic tethers, which are done thoracoscopically. You saw a picture of a thoracoscopic approach where we use cameras in the chest, and the lumbar tethers, which generally speaking need to be done through an open approach. We've gotten a lot better at minimizing that open approach, and we often do a combined approach where we insert the top couple screws thoracoscopically above the diaphragm, and then do not take down the diaphragm, and then go retroperineally through a small incision below. I get into all that because the type of approach is related to the type of complications. So if you're doing a thoracoscopic approach in the chest, there are complications related to the potential for lung issue, atelectasis, and there are some people who early on had concerns about the lungs not fully recovering or not fully re-expanding. It doesn't seem like that's really the case, except perhaps when you have to go back a second time and do something in the chest. And it does look like the second approach to the chest, where there's more scarring and more adhesions, might result in some issues with pulmonary function. So that's one of the things we're concerned about in the thoracoscopic approaches, particularly in revision cases. Of course, we're operating, with a camera through, next to big vessels, and there is a rate of vessel injury, segmental vessel injury, although significant complications really have been quite rare. In the lumbar spine, there's been a number of complications related to the nearby anatomy, including ureters, kidneys, and also the lumbar plexus. And there is a number of kids that the rate is probably in the single percentages, maybe 5%, who wake up with some autonomic nerve issues, meaning that in approaching the lumbar spine, you disrupt, a plexus of autonomic nerves that run down in that area through the leg. And some kids have had issues with heat intolerance or some swelling of the leg. It generally gets better, but it's something that now we counsel our patients about. The rate of infection is actually quite low, both in the tethering and the fusion procedures, and it's probably somewhere in the 1 in 500 rate. The rate of transfusion also quite low for both procedures, probably around 2 to 3%, maybe lower for the tether. So somewhat different types of complications, but overall somewhat more complications with tether, at least as we understand it in our current sort of stage in this journey that we're in. Thanks,
Dr. Vitale. I love our team at Columbia. I just realized John Tunney was an audience, and I figured maybe if he's able to jump on. So I apologize. You'll see his video, and under it's my name because I just quickly sent him my link. But this is the incredible orthotist, John Tunney, who has revolutionized a lot of scoliosis bracing, and he did make the brace that that our patient that we're discussing has made. And there's been some questions around, was it a similar brace than a kid that, it's treated non-operatively? And then what was the prescription for the brace wear for this patient? John, you're still muted. There you go.
All right, got me. Sorry about that, guys. As far as the brace goes, I had never done one before because this is a kind of a new thing that we're doing. So I kind of started with the assumption that the patient would still actually be flexible, which is the whole point of the tether in the first place. And my biggest worry was usually patients post-surgery don't have as much flexibility. And then secondly, a lot of times where you need to push is where the incision is. So I know we talked about this a lot in the beginning about applying the brace immediately post-op versus 6 weeks later. And I kind of think the 6 weeks later was a much better choice because it allowed me to actually put some pressure in that area without big problems with pain. Because I think that's something that can kind of derail bracing afterwards if they get immediate pain. It gave Trella a little bit of a chance to kind of work on her, work out some of the flexibility things. And then I actually just made it much like a regular brace. I kind of made all the same assumptions as far as modifications. And I was planning to do a whole lot of work, quite honestly, when she came back in. But probably because of her dedication, she corrected almost like a regular brace patient, which was kind of interesting. It wasn't what I was expecting.
Great. Thank you, John. And thank you so much for jumping on so quickly. I really appreciate it. I have an incredible physical therapist, Marissa, who jumped on. She runs a very successful non-op practice also. And it's a really interesting question. Dr. Vitale, as a physical therapist, we label compensatory curves, primary curves in different ways. How do you as a surgeon define it, just to see that we're all sort of on the same page?
Yeah, I think generally we think about the main curve as being the largest curve, and then the secondary curves being structural or not structural based on the size, flexibility if we have bending x-rays, but also the amount of deviation from the midline and the amount of rotation of those curves. And as those four things increase, rotation, deviation from the midline, size, and flexibility, the curve sort of personality, if you will, changes and becomes a curve that's more likely to progress, that can be harder to treat with conservative measures and may not be as responsive in terms of spontaneous resolution after treatment of the main curve. So those are the things we generally look at.
As a physical therapy that treats the whole lifespan, I'm sure other physical therapists have come across who are in the same space. What do you say about adults that are done growing but are in surgical range, who are being sought after other surgeons who are pushing for adult tethering procedures? And just your advice from a professional standpoint, how you can advise us just to better help patients.
Yeah, very controversial area, as you know, Prachi. In fact, I think that across the country, there's really only two groups that are doing adult tethering. And there's been no publications, no research, no sort of documentation of that. I think that if you understand how tethering works as a tool for growth modulation, and understand that the reality that a tether will always break, because in any non-fusion construct, repetitive stress across any material will result in eventual failure with enough cycles. It's hard for us to sort of understand how tethering is going to work in a skeletally mature patient, especially as it's sometimes been used in 40, 50, 60-year-old patients. Some of our societies have also had some significant concern about some of this, because it's not only not FDA approved, but it hasn't been done with the same intellectual rigor that studies of children have been done. In other words, there's no study group studying it. We don't have hundreds of patients studied for many years in rigorous ways. So all of those things should make you feel buyer beware, caveat emptor. And although it's may be appealing to think, well, perhaps I can avoid fusion, I would at the very least suggest to those patients who are being sold a tether for in the setting of a skeletal maturity to get some other opinions, see some other experienced physicians, and get the whole range of outcomes, options, and perspectives, because it's a big decision. And the huge majority of us involved in the space feel like it's probably not something that in the long run will be the right thing for patients.
Wow, that's really clear and interesting, Dr. Vitale. Thank you for your very great expert opinion. Trella, I'm curious, since this was such an unusual case, how aggressively were you directing derotation in all of the poses, and which position in someone like that was such a competent mover did you find the best correction?
That's a really good question, Prachi. So I, once she was in the brace, I increased how intense I was, but I would say I worked more in the sagittal plane versus the frontal plane for a long time to affect for the derotation force, I would say. And then I found to effectively work on both curves, I found the best correction in side lying once I felt like it was okay for her to do that on the right side. So we did right side lying, and I did a lot in like seated on a physio ball and standing. Those were like the best positions that I could get corrections for, depending on where I was applying force or how I was asking her to do shoulder traction, counter traction, for example. I think I answered all your questions. I think.
Yeah, you did.
Okay.
Yeah, no, that was perfect.
Actually, I love the term that you just used, competent mover, because it's something I think about a lot. It's not something we've sort of studied, but I think that's a very real thing. There are some patients who you can predict just have a phenotype that are going to do really well with PSSE, engage, be, body self-aware. And then there are others that, that are going to be a lot different. Do you think there's any way to sort of predict that? And should we be thinking about that with regard to informed consent in a procedure where post-operative PSSE is probably very important?
Yeah, that is a great discussion. My dear friend, who also used to work at Columbia, Hagit Berdyshevsky, along with Lori Dolan and Lisa Stoll, says that's what they're working on, is defining competency with movement. And I think us as physical therapists can help greatly in this space. I think, and we've had this conversation before, we think of core strength, and a lot of people are like, let's have them hold planks. But it's very interesting, especially someone who's very hypermobile. You put them in quadruped, for instance, and they can't even hold quadruped. Their head's falling down, their back is drooping, and oftentimes they might need tactile cues, like putting something on their back, or something like this. And Marissa also did, publish just a really great article. I can post it in the group chat if that's helpful. And maybe she'll just send me a link for it, where she did talk about the roles of motor learning in this space. But I think this is a definitely up and coming field, and I think there's a lot of work we can do around having a competent mover and how quickly we can push them forward. But then also, more importantly, the non-competent mover, how to help them become more self-aware of their own body. So Dr. Vitale, have you found any difference in, and maybe Amber might also be able to speak for this, she's Dr. Vitale's PA. Have you found a difference in reimbursement insurance-wise for a tethered patient versus someone who's just getting a spinal fusion?
Yeah, Amber and the rest of my team can sort of share that because the data is only evolving now, it definitely takes more effort, and sometimes it's not even possible to get the insurance companies to pay for tethers. It's very dependent on which insurance company. Many of the large insurance companies have now interpreted the massive data as they should, supportive enough of considering coverage. The problem is that in situations where it's not covered by insurance, some of these patients are going out of network, and particularly in the places where adult tethering is being done, because there's no insurance company that would cover adult tethering. These patients are incurring very, very, very high charges, like sometimes $100,000 of charges. And so, I think we need to be careful here. I mean, part of it requires advocacy with the FDA, insurance companies, when there is a literature showing evidence and evidence showing efficacy and safety. But I don't think it's the right answer to say, well, if you want to have your tether done, it's going to be $100,000 thing, because that's a huge burden on these patients. And there probably is a reason why the adult patients are not covered by insurance companies today. One of the things that Amber and my team do is maintain a file of current literature, which we send to the insurance companies, because if you look at the literature, it's really evolving quickly and much different than it was 5 or 10 years ago, where it was basically non-existent. And now there's really well done large studies with good follow-up and showing reasonable outcomes. So I think that this space is evolving, but it's a good question, Prachi. It's a source of frustration for patients for sure.
Amber, just wondering if there was anything else you wanted to add, since you do a lot of the back end work for Dr. Vitale.
No, I mean, that's really what it is. Like you preemptively, when you're working with insurance companies, just go ahead and give them the information ahead of time instead of waiting for them to come back. I think that's good for when you're trying to get a Rigo style brace. I think that's good for Schroth. I think that's good for, any of those type of things to go ahead and hand them the research ahead of time instead of waiting for them to come back to denied and then you have to submit all the paperwork. So I think that that's a better way of doing it.
Dr. Vitale, we have another question for you that just came in. Does the double tether address rotation better than a single because it crosses, or do they run sort of parallel to one another?
Yeah, that's a great question. Obviously, someone who has a good sense of sort of what's going on here biomechanically. It's almost impossible for a single row tether to address rotation. It's like having a towel that you're just turning one way and you can't really stop. You can't create, rotation or can't unrotate it. The hope is that a double tether may give us a little bit better ability, but we are still always going to be much, much better controlling rotation through a posterior fusion approach. So it's still unclear whether the double tether has an advantage that way. Don't get me wrong, there are documented relatively small but real improvements in rotation from tethering, because the improvement in the frontal plane is linked or coupled with the improvement in the axial plane. But generally speaking, if someone's really concerned about rotational asymmetry and the cosmetic part of that, they're not going to be as happy with the cosmetic result of a tether compared to a fusion.
So another question that came through is, when do you decide that a patient needs a fusion? Besides the obvious that the tether broke, is there any other parameters that you then have to go back in and do a fusion surgery?
I think that the things that push us to revise, and I feel sort of fortunate in doing tethers for a number of years. I still have not revised any of these kids. I think if you're really, really selective about indications, you're less likely to get to a place where you're having to reoperate. But I'm sure that that's coming. But the things that push you to revise a kid is overcorrection, in which case we'll sometimes go in and literally snip or loosen the tether. And that's sort of proof of concept. If the curve is overcorrecting and imparting secondary curves above or below, we'll sometimes go in and do that. But most often, if you don't get adequate correction, and if the curve continues to progress, and if we're concerned that now we're developing other curves. So one of the things that we're trying to look at very critically is whether or not the final fusion levels are the same if you were to fuse that kid at the outset, or in the subset of patients who are tethered, progress, and then need a fusion. Because that'll be an important piece of information for us to know. If you can get away with a fusion to L1 at the beginning, but doing the tether in the 15% of the time that it fails results in the curve progressing and requiring a fusion to L3, that's not a great outcome. And we're trying to figure all those things out. We're still not there.
Thank you so much, Dr. Vitale. I was just before we run out of time, I hope everyone's enjoyed the lunch and learn. Everyone's going to be getting an evaluation. If there's certain topics that you want us to cover, that would be wonderful. We already have our next one already planned. It's on that registration link. And I'm just wondering if there's any other questions. Oh, I have one question. I don't know if John is still on, but he mentioned this is the first time he's ever had to brace someone that's tethered. Dr. Vitale or John, is this routine to brace someone post tether? Is this brand new thinking? Just curious. At Columbia, we've seen a bunch of tethers, but from other surgeons, and even though they have a residual curve, there's been no bracing or anything like this.
I think we think about bracing in situations where there's significant growth remaining, which hopefully there always is in a tether, and where there's not enough of a curve correction or a significant secondary curve. So the thing that really led us to brace this kid was the 54-degree untethered thoracic curve rather than the lumbar curve, where we actually got quite nice correction. And this is another area that's controversial, although I think that many providers are using a brace for a period of time, even if it's not a majority.
Okay, wonderful. I think that concludes our talk today. We hope that you enjoyed it and learned something. I know I definitely did. And I hope you can join us next time. And we hope to continue bringing a lot of this very lively discussion and just hopefully all learning and improving quality of life for all our patients.
Thanks so much for your help in organizing, Prachi and Amber and Trella. I really appreciate it. As always, learned a lot from you guys.
All right. Thank you so much, everybody.
Have a great day.